Well, Rod, thank you so much. You and Jens and everybody else, you've really proven over the years that you have an amazing academic institution with just an amazing educational program that you've put together now for, as you mentioned, 13 years. That's quite remarkable. And I've watched it, and I've been fortunate enough to be part of this as well. I would love to be there in person. I apologize; it just didn't work out. But I'll talk to you about a topic that obviously that's very important to me, MIS and to everybody, complication avoidance. And I'll talk a little bit about in general, maybe MIS, and then my thoughts about how that plays out in terms of avoiding complications or addressing potential complications. Now, I know this is a course that really covers various topics of spine surgery, so I just put this in here as a definition of MIS, basically an operation. You're trying to achieve the same goal, but with less complications and hopefully a smaller surgical footprint, so less tissue damage. But again, you really want to achieve the same goals. And in every case, you got to make that rational determination beforehand. When you see the patient, you look at the films, is this really a good case for MIS? Because if it's not, then it's better done open. We have the ability to address most pathologies in the spine with less invasive and minimally invasive surgery, really. And the idea obviously is small incision, less soft tissue damage, less blood loss, lower complication rates, hopefully. But again, this still needs to be proven to a certain extent. I mean, we think that we can achieve this, but there's certainly no class 1 evidence. If you plot the complexity of an operation against the invasiveness, you'll see that with open traditional surgery, that invasiveness goes up pretty quickly. So even a relatively less complex operation already is relatively invasive in terms of length of incision, infection risk, and bleeding and so forth. And the whole idea with MIS is to dampen that curve. And where does that make sense? In my opinion, it makes sense in this mid portion of spine surgery. And the mid portion for degenerative disease, I would say, is or are patients who have single or multi-level lumbar stenosis, maybe spondylolisthesis, or patients who need a 2, 3, 4, 5 level fusion. Those are the mid-complex cases where I think MIS is doing a really, really good job. And we have a decent amount of data now that we get these patients home safer and faster. There's low infection risk and so forth. The extremes, however, I think the really simple pathologies, like a lumbar disc herniation, for example, or the complex deformity cases, I think MIS, we're still not sure if MIS is really the right answer right now. I would say if you have a lumbar disc herniation, whether you do that with the endoscope, with a tube, or even with a microscope, with a bigger incision, it's not really a huge difference. But I think overall, interestingly, about 3/4 of spinal surgeries can be addressed partially or completely with MIS technology. And what are those parts of MIS? What does the surgeon have to consider on your journey to becoming a minimally invasive spine surgeon? We put this together, and this obviously applies for many other surgical specialties as well. But I think especially for MIS, it's about the 6 T's, and the number 1 is certainly target, and that's patient selection. And I would say that the majority of your complications you can already avoid by spending a lot of time picking the right patient for the right operation, or the right operation for the right patient. And then obviously you got to be familiar with tools and technologies. You got to know how to use your fluoroscopy, your navigation, your microscope, or your endoscope. And then you got to train surgical techniques, and that's very important in terms of avoiding complications. And that's what the beauty at the Seattle Science Foundation, that obviously you've got a wonderful cadaver lab and surgical simulation opportunities where you can train these, and this will translate in better outcomes and less complications for your spine surgery. And then teaching and training, research, we're not going to talk about that a lot. We just came out with a book that kind of summarizes a lot of the things that I'm talking about. Let's talk a little bit about target, surgical target, or patient selection, which is something that we rarely really discuss. So and it's a little bit different with MIS than it is with open surgery. With MIS, we really try to identify exactly the pathology that's causing the patient's symptoms, and then we try to really focus with our surgical treatment and the surgical approach to treat that underlying pathology. And that's sometimes different from open surgery, where you have the luxury of treating maybe pathologies that are not yet relevant, but may become a problem in the future. That's the philosophical difference between MIS and open surgery. But that requires the goal with MIS then, where you really want to identify exactly why is that patient in your office, what's causing those symptoms, requires a very thorough preoperative workup. And you've got to understand exactly the correlation between the MRI scan and the clinical symptoms. What causes radicular pain versus neurogenic claudication? What's causing mechanical instability with what's the definition of mechanical back pain? So you know when do you have to fuse a patient, and when do you maybe able to avoid a fusion and just do a decompression? So the clinical judgment and the clinical workup of these patients is really important. Much more important, I would challenge with MIS than it is with open surgery. So you want to minimize over-treating patients, and you want to minimize prophylactic surgery. This is a good example. This is a patient I saw. This patient came from Europe a few years ago. She had two tiny incisions. You could barely see the incisions. And she came in essentially with neurogenic claudication a year after the previous surgery. And she had this surgery done in Europe somewhere by a very accomplished and known surgeon who's great. I got the x-rays, I got the CT scan, the fusion looks great, everything looks amazing, but she had exactly the same symptoms that she had before surgery. And then we got the MRI scan, and she essentially had lumbar spinal stenosis. And that had not been treated. They did a fusion, minimally invasive, technically great, but they didn't treat the pathology. And that's my point. You really have to obviously treat the underlying problem. You got to identify the underlying problem first. So this patient then underwent a tubular decompression. And now not only did she have lumbar stenosis still at the treated level, she had adjacent segment disease now because of the fusion. So we treated both levels just with a tubular decompression. I think this is just a great example where an operation was done technically perfectly well, but it was just missing the pathology. So you got to select the right treatment for the right patient. You got to correlate the symptoms and imaging findings and precisely target the pain generator. So these we all know these patients from clinic. This is not a good surgical patient, right? So certainly not for MIS. So you got to keep that in mind, and that's an obvious no-no. Now, surgical decision making. Again, if you want to avoid a complication, make the right surgical decision from the get-go. So if you want to do a minimally invasive spine surgery or any spine surgery, you got to carefully examine the patient, and there has to be a correlation between the symptoms, the imaging, the history, and whatever other testing you get. Now, we work in a multidisciplinary spine center, so because of this importance, many of my patients undergo diagnostic nerve blocks, maybe an EMG. I review the films with the neuroradiologist to make sure I'm not missing anything. So this is really the most important part. Then the next step is, before you make your surgical decision, you have to understand the natural history of the disease. And we just don't know that. In many disease patterns, we just don't know the natural history that well. For example, grade 1 spondylolisthesis and the degenerative grade 1 spondylolisthesis. The natural history is probably not devastating. Probably many of these patients, and we're just reviewing that and publishing that right now, about a third of those patients with degenerative spondylolisthesis will deteriorate over time. That means 2/3 will not. So it's important to take that into your consideration in the decision. For example, are you going to do a fusion, or are you just going to do a decompression for patients with spondylolisthesis and severe lumbar spinal stenosis? If you knew that 100% of these patients are going to get worse regardless of surgery, then you know you got to do a fusion. But since it's only 30%, I think it gives you a little bit more ability here to tailor your treatment decision based on the patient's expectations and pathologies. And then you got to know the impact of your surgery on the disease process. For example, a great example against spondylolisthesis with lumbar spinal stenosis, if you do this open and you remove part of the facets, that patient is probably going to need a fusion because you're causing iatrogenic instability. If you do that if you do the same decompression though with the endoscope or with a tube, will protect the facets, and it's much less likely that this patient will need a fusion. So all these things then come together and will guide you down the path to the right treatment decision, whether it's MIS or open. But those are the three things that I always keep in mind when I look at these patients. And I think in terms of complication avoidance, I think it's important to keep this in mind. And then there are some other factors, social, lifestyle, patient expectations, and so forth. Now, we all know what complications are, of course. We're not going to go into that. In terms of MIS, the complications that are, the least desirable and the ones that we kind of encounter every once in a while are obviously nerve injury, nerve damage, CSF leak. Who doesn't know about that? Screw misplacement, KY complications, bowel injuries with lateral or anterior approaches sometimes, skin necrosis, because we're making all these, a million small skin incisions, and sometimes they're too close to other incisions, and that can cause skin necrosis. I'm going to address some of these problems in the remainder of the talk. We published, obviously, a lot of papers addressing MIS. This was a paper that was published a while back, reviewing the data on MIS TLIF open versus MIS. And even back then, the reported rate of complications was less with MIS than with open. And I think for the most part, most authors really have seen that over the years, is that you see less complications with MIS surgery. And why is that? Well, a big reason is that infection is almost zero. Infection rate with endoscopy, with tubular surgery, whether it's a decompression or decompression infusion, like a TLIF procedure, for example, or lateral surgery, infection is almost non-existent. And I think a lot of studies have shown that. And why is that? It's probably has to do with an open operation. You make a longer incision, there's more exposure of soft tissue to the environment. With a tubular surgery, you don't expose anything really, and the tube kind of protects the soft tissue. With the endoscope, obviously, you have constant irrigation of the field with saline. So all these things, all these factors really prevent significant infections. CSF leaks, right? Certainly, one of the challenges, especially with tubular surgery, and I've been through the whole learning curve. The lessons that I've learned with CSF leaks, and sometimes you hear surgeons talk, they talk cavalier way about CSF leaks through tubes. You can just ignore them or just put glue on it. I think you have to be more. You have to be more rational. If you have a leak through a tube, if you do a tubular decompression, a TLIF or a tubular over-the-top decompression, and there is a leak where a nerve root is sticking out, then I'll always make sure that I drain CSF. The key to closing CSF leaks through the tubes is to take your time and drain a lot of CSF. Sometimes you drain for 10, 15 minutes, everything collapses, makes it much easier. So then you can gently reinsert the nerve root into the thecal sac, and then you got to try to put a stitch in there. There are different ways of doing that. I talked to, I think it was Rick Fessler, Kevin Foley many years ago, and they told me about an endoscopic dual repair set that I have now that I've been using for this. But there are other, I think Dean Chow uses just a needle holder and bayonets. There are different ways of doing it. There's no perfect solution.
Roger.
Yes.
Hey, it's David Okonkwo. Good to see you, man.
Good seeing you. I can't see you, but I hear you. Yeah.
Hey, you had me the whole time. I'm so down with every single thing that you've said, and respect, your contributions to all of this. You had me all the way up until you said drain a lot of CSF.
Uh-oh.
And so I'm just a little bit curious about that. And I've got my few friends back here, Charlie, Sanser, and Kojo.
I think what David may be alluding to is perhaps you drain a lot of CSF when you want to get the nerve to go back in.
Yes.
And not if the nerve is not popping out, then you don't need to drain the CSF.
Yeah.
No.
Yeah. Okay. But it's also once a year that we take care of someone with a posterior fossa hemorrhage or a subdural hematoma from CSF drainage from a durotomy in the lumbar cistern. So I'm that wouldn't be my particular way of handling this. If it's worked for you, that's fantastic. But we're in an audience of trainees, and I think for this particular point, I give you a high five for every single thing that you've said up until this moment. I would just say that there may be an alternative perspective about the concept of draining CSF to repair a duotomy. But that's been a successful strategy for you.
Yeah, so let me elaborate. I'm not talking about draining, like, I mean, when I say a lot of CSF, all I'm saying is that you spend 10, 15 minutes sometimes, if there are a lot of nerve roots herniated out. I mean, sometimes you don't have to drain any because the nerve just goes back in there. But sometimes you have a situation where there are like multiple nerve roots herniating out and you just can't get them back in. In that situation, I put a patty on the dura and the nerve roots, and I drain CSF for 10, just maybe 5 minutes, 10 minutes, until everything kind of eases up and you can put the nerve roots back in. Now, obviously, then you have to close it, and then you wait, and then everything comes back. The key is closure. I think once you close the CSF leak, whether you drain 5 or 10 minutes or 15 minutes, that's the key. You have to close the hole. Once you close the hole, there's not going to be a hemorrhage. I mean, the hemorrhages happen if patients have a continuous CSF leak, and then they get up and they walk around, and that's the problem. If you don't treat it properly, that's and I've seen that myself, or subdural hematoma. I'm just talking intraoperatively. In the process of closing the leak, you drain some CSF until the nerve roots go back in. And the point is, again, once the nerve roots come out, you really have to make sure that they go back in, and you put some stitches in there. But it's an interesting. I appreciate your comment because I get your point. But I think that hopefully I explained my point. This is the system. These are the tools that I use now. The Scan and Endure Repair Set is a tool set that you can purchase if you're interested in that. Of course, I have no interest in this, but that's the one that I use. And then obviously the other lesson that I've learned is if patients come back with persistent CSF leaks, then you really have to open it up. You have to find the leak, and then usually get plastic surgery involved, and close the leak, and then have plastic surgery help with the muscle closure, especially if it was an open case. Maybe not necessarily an MIS revision case, but certainly in a case where there was open surgery involved before, and that's been very, very successful. So screw loosening, okay? Screw loosening. How many more minutes do I have? 7 minutes?
You're fine, Roger. You got time.
So another problem with MIS is the inability of achieving fusion, especially if you're really more relying on posterolateral fusion. That's why we're doing a discectomy, and I always trying to achieve an interbody fusion. So in my experience, for this type of surgery, the importance is really the discectomy. You got to spend a lot of time with a discectomy, and you got to expose the end plates. And again, I don't want to come back to the CSF leak, but I said I mentioned a lot of time draining fluid sometimes, but here I certainly mention take my time when I do the discectomy. And sometimes doing the discectomy takes 15, 20, 25 minutes because it is so important to get the end plates exposed. And I use autograft bone. We've published that experience. Avelino Parajon published a meta-analysis with our group where the highest, other than using BMP, the highest fusion rates for MIS TLIF really you can achieve by using autograft bone, and if you need to, with some kind of bone substitute on top of that. So I use iliac crest bone or bone from the facet joint, obviously. I do the discectomy, very thorough discectomy. I put the bone graft into the disc defect, and then I put a cage, and then I backfill the cage with bone graft as well. And then and that has resulted in a very, very high fusion rate. And I still put some bone posterolateral, but I certainly don't rely on that as a main fusion mechanism. It's really the interbody fusion that matters. Expandable cages. Now, I work a lot with expandable cages, and I like them. The challenge here, as you can see on this film, overall it looks like a nice result. However, there's some subsidence into the end plates, and that's because these cages are so powerful. So that's also been a learning curve in my practice, where I really try to get the tactile feedback. I don't use fluoroscopy. If you have fluoroscopy, obviously you can check, but I use everything with navigation. So you really have to get the tactile feedback when you expand these cages, that you don't overexpand these cages. But I think overall, if you take that into consideration, I think expandable cages are an amazing adjunct to what we do in MIS. I don't use K-wires anymore. I got away from K-wires many years ago, and this is one of the reasons why. Initially, I would use navigated screws, percutaneous screws, but I would put in K-wires and then cannulate over those K-wires and then put in the pedicle screws. This is a case that I had many years ago, and you can see that K-wire sticking out right next to the blood vessel. And that was certainly one of the reasons why I stopped using K-wires. We explored this with one of our laparoscopic surgeons. We explored this, and we removed the K-wire. This is the revision surgery where we removed the K-wire. It was quite scary for that reason, but also for, to avoid misplacement of screws, of course. I use now a pedicle screw system that you're probably familiar with, and several companies have that. It's an integrated pedicle screw system that has an integrated K-wire, so not a separate K-wire, where you navigate the whole screw system here, and it has an integrated K-wire, very, very aggressive screw tip, and it makes it not only safer, but it makes it also much, much faster to place these pedicle screws. Every once in a while, you still have to use a separate tab if the bone is really hard, but for the most part, this is a great way of putting in pedicle screws. We published our experience recently here, and then that's that. I think we're done, right, with time? Yeah.
Yeah, we're getting. You have a minute.
Okay, great. So we well, the last thing I want to show you here, I spend a lot of time teaching and training. The tubular surgery, obviously, that was really evolved with Kevin Foley's work, Rick Fessler, Larry Koo, and many others. But they never really, in my opinion, they never really wrote it up properly for people to really teach and train. So we published this paper in 2017, and then I did a lot of work with the AO over the years, putting together treatment, step-by-step descriptions of certain surgical techniques for MIS. And we published this within the AO. Unfortunately, it's only available at AO courses currently. Hopefully, we'll be able to expand that and use that at courses like yours. But it goes very nicely through the step-by-step techniques for tubular surgery, MIS TLIF, lateral surgery, and so forth. So we have a lot of educational material. And we put together a step-by-step technique for tubular decompression for lumbar laminectomy, right? And then we did a study. We did a Delphi analysis where we had various surgeons chip in, and we developed a protocol with about 40 detailed steps on how to do a tubular laminectomy for lumbar spinal stenosis. And we had residents and fellows follow this protocol and do it 3 times in a real spine model, such as the one here. We just published this recently. So we had residents do this and fellows 3 times in a row, and then we measured the number of complications, the time it took to do this operation. And as you would expect, obviously after three of these procedures, the time of the surgery decreased significantly. They stuck to the protocol better. And most importantly for this presentation, I think that the errors and the complications dropped significantly. So there was less CSF leaks. They didn't drill through the pars anymore. So that just goes to tell you that not only is it training, but it's also surgical simulation, that you can do this in cadavers. I personally think surgical simulation with these spine stud models or real spine models is probably much superior. The more you have your residents and fellows do this, the less complications and the faster they're going to be, and the easier it's going to be for them to translate that into their practice. I think I'm going to stop here. I really appreciate your time. I also appreciate your comments. I think that's really important, and I hope that this was helpful.
Are there questions for Dr. Hartold from our participants? I have a question for you. It's David Akakwo again. for your MIS decompressions, so no instrumentation, no interbodies, are you navigating those as well? Or how are you using fluoro? What are you doing for your compression non-instrumentation MIS cases?
Yeah, so I got to say that we have a number of navigation systems here, and then over everything evolves. Initially, we used it for screws, and since we have it available, and we're really, and everybody here knows how to use it, I started using it for my multi-level tubular laminectomies. Like if I do a 2 or 3 or 4 level tubular laminectomy, I use navigation. Because it's just easier than calling in an X-ray tech for every level and get another lateral fluoro shot. It's also better for resident education, resident training. I come in, they show me exactly where they are on the navigation screen, so it allows me to let them do maybe more. But it really improves the workflow. So for multi-level MIS tubular decompression, absolutely, I use navigation. Also use it to protect the pars. I operate on a neurosurgeon here from the city recently who had previous surgery, and we discussed it, and he absolutely wanted me to use navigation because he was worried about injuring the pars in a revision situation. So I definitely would use navigation for this, and do use it.
Yeah, this is Charlie Sansur. I'm going to add to that and say, if you're doing a minimally invasive thoracic disc, for instance, like a posterolateral thoracic disc, and if it's partially calcified, navigation might also be helpful in that scenario too.
Yeah, we use it for far lateral discs routinely now. For cervical foraminotomies, just at C6, 7, rather than getting a million fluoro shots, you navigate and you're right there.
Hey, Roger, that was an excellent talk. This is Rod. So tell me, if you have, what's your cutoff for doing MIS fusions? Because I think for me, I can see, okay, 1 level TLIF, I agree with you. MIS surgery is a great option. But what about that L2 to sacrum? Or how about that, 3 or 4 level? What's your cutoff? And do you think there's a role for MIS surgery in deformities?
Yeah, I think it's very complicated. I do 2-level TLIFs, maybe rarely, or sometimes a combination of lateral surgery and TLIFs. I think once it becomes more, once you have to really treat and fuse more than 3 or 4 levels, then in my opinion, it becomes a totally different operation. It becomes a deformity surgery. In my opinion, deformity is something, it's like aneurysm surgery in the brain. That needs to be done by people who really understand deformities and know how to treat them, and also understand the long-term implications. Now, working with Larry Lenke now here, for example, and Sardar and Kai Fu and all these others, for me, it just makes much more sense than if I really think somebody needs that type of surgery, I refer them to a good deformity surgeon, and then they make the decision. I think the goal is to perform the operation for the right reason, technically perfectly well. Whether it's done open or MIS, at that point, I don't really care. I think it just needs to be done properly. And then that's my honest opinion.
Hey, Roger. Pimenta.
I know you. I've heard about you.
You heard about me? Good. So don't you think that the limit of MIS is not only technical, is the lack of lordosis, right? For instance, that you can do 2, 3 levels of MIS TLIFs, of course, but then can you give to the patient back the doses that they require? So, and this has been in my kind of long career, right?
Yeah, and I know exactly what you're saying. We've discussed this many times, and I totally agree. But those are decisions. That's the target philosophy, right? That's the first. If you make the decision before surgery that this patient really needs lordosis, then TLIF is not the right operation. I mean, I think nobody would disagree with that. The question is really, is that, but that's a decision you make before the surgery. And then if that patient needs an ALIF procedure or something else, then that's perfectly fine. But it's not a decision that you make intra-op and then you realize, oh, now I'm stuck with a TLIF. You got to make that. I totally agree. I just think that the question is really who needs lordosis, right? That's the question. I mean, who really needs? I think we all, you maybe think more than some other surgeons may think. Well, maybe that patient doesn't need lordosis. I think that's the big question.
Great. Thanks again, Roger.
Thanks for having me.
We'll obviously miss you seeing you in person, but really appreciate your talk and all your insights into doing MIS surgery. Good to see you.
Thanks, Luis. Bye-bye.
So we're going to switch to the lab now. And